Hi, everyone, and welcome to the Otolaryngology Clinics podcast series. I'm Stacy Eastman, the managing editor for the series here at Elsevier. Otolaryngology Clinics is a bi-monthly publication consisting of review articles focused on a central topic. Today, we will be discussing the August 2022 issue dedicated to gender affirmation surgery in otolaryngology. Guest edited by Drs. Regina Rodman and Michael Haben. Here now is the consulting editor, Dr. Sujana Chandrasekhar, to lead the discussion.
I'm Dr. Sujana Chandrasekhar. I'm the consulting editor of Otolaryngology Clinics of North America. And today I'm speaking with the guest editors of the August 2022 issue of Clinics on gender affirmation surgery in otolaryngology, Drs. Regina Rodman and C. Michael Haben. Dr. Rodman is a facial plastic surgeon and the owner of Face Forward, a private practice in Houston, Texas. Dr. Haben is a laryngologist and director of the Center for the Care of the Professional Voice, Haben Practice for Voice and Laryngeal Laser Surgery in Rochester, New York. Welcome to both of you. About 1.4 million Americans identify as transgender, and that number is likely too low. Gender affirmation is a topic that is challenging on many fronts, and discrimination that these patients often face from their families, from society, from politicians, and even from healthcare personnel. And I think it's really imperative as healthcare providers approach them with the compassion that we approach all patients with, as well as with comprehensive knowledge about this area, which is relatively new. There is a term called gender dysphoria, and it is the feeling that someone has when they have been born into a gender that they really do not feel defines them or identifies them correctly. And that can be very, very hurtful. And I think it's really important for healthcare professionals to acknowledge the pain that gender dysphoria can cause. This past June, I was in the locker room with one of the PAs right before the New York City Pride Parade. And she was telling me that she works for a, quote, top surgeon, meaning breast surgery in gender affirmation. And I said, well, if you guys do top surgery, then ENTs do apex surgery. Right. So we take care of how the face looks and how the voice sounds and, whether we have a prominent Adam's apple, let's say. It was interesting for somebody like her who's worked with transgender patients so frequently, she really wasn't aware of the contribution that otolaryngology makes to improve quality of life in these individuals. Both of you, Regina and Michael, have put together 17 articles that cover gender affirmation in otolaryngology thoroughly. So let's talk about some of these concepts. So Regina, what's the correct approach to the transgender patient, particularly in terms of setting appropriate expectations in someone who's considering facial feminization surgery?
Setting expectations is the key. I think that's the foundation for a successful and happy surgery. There's several things that I do in my pre-op exam. As Dr. Haben and I were talking, a lot of our patients come from out of town. So often my first history and physical is done online. I generally ask patients a lot about themselves, not just their medical history and hormones and things like that, but what do they do with their days? Do they work? What do they like to do outside of work? I always ask what their support system is. I want to know, do they have a significant other, a spouse? Do they have kids? Do they have family that supports them? And I also always ask, just tell me a little bit about your transition. And I will often follow that with, was your family supportive? Was your parents supportive? It is not a requirement, but I have found that patients who have some type of a support system, whether it's family or they have found a community, just do better after surgery. Not necessarily in terms of physical healing, but just in like how they feel about themselves and how often they call the office and how often they have positive feelings. So the other thing that I do is try to draw a distinction, which is impossible to draw it cleanly, between beauty and femininity. So, I think in our society today, we value youth and beauty as femininity, but they're not the exact same thing. And so, especially for older patients, I try to clarify that I'm able to make them look more feminine, but that doesn't necessarily mean that they're going to look younger or more beautiful. I try to tell them you're going to look like a sister version of yourself, not a whole different person. And I think that's also sometimes helpful on the flip side is I have family, a significant other, a spouse will be worried I'm not going to be able to recognize her. She's going to be a whole different person. No, she'll be the same, just a slightly softer, more feminized version of herself.
Those expectations and really being concrete, frankly, about those things sound really important. Michael, where in the process of transitioning from male to female or vice versa, does the patient then either see or get recommended to see someone for gender affirmation voice surgery or voice intervention?
That's actually a very, very interesting and very complicated question for a lot of reasons. We actually have 5 chapters and each of those chapters has a slightly different take on when and where patients should be considered. For example, on the chapter on feminization voice surgery, there's one approach. Masculinization will have a slightly different approach. The gender affirmation hormone therapy has a different approach. And then the 2 voice chapters actually have some very interesting insight. In particular, one that's written by Ms. Huff, who is transgendered herself and brings a very unique approach to a transitioning as far as the voice. But the very simple answer is it tends to be either the very first thing that folks do or the very last thing that folks do, and for very different reasons. The reason that it's the first for a lot of folks is very simple. In someone who has already transitioned physically, they can walk down the street, they can interact socially, they can be seen without being, quote unquote, given away. A lot of transgendered women who have not mastered the voice or who have voices that are not congruent with the way they look, as soon as they open their mouth, they feel that they've been given away. So that is a huge source of dysphoria for them. Now, I've been told by a lot of women that they will sometimes literally stay in their house until they have transitioned physically because they can hide their physical looks until they have gone through the process of transitioning. But invariably, folks have to work, they have to interact with other people. And as soon as they pick up the phone, even though there's no visual cues over the telephone, their voice immediately gives them away. And that is beyond disheartening to be misgendered over the telephone, whether or not that they have any physical cues that will or will not give them away. Now, the difficult thing with transitioning from a voice standpoint is that I guess the best way to think about it is this. In a cisgendered female, they have a cisgendered female larynx and vocal tract. They spend their formative years listening to other cisgendered females and subconsciously, mimicking those speech patterns, et cetera, using their, little girl voice box. Now, to take a cisgendered male's voice box or a transgendered female's that has already reached maturity and then try to teach an individual to use those same cues is extremely difficult unless you are very, very talented. The analogy I use is there are those that have a musical ear and they can just hear things that the rest of us can't necessarily put our finger on. And then there are those of us that are just purely tone deaf. And it's really frustrating to be told to mimic something when you don't necessarily have the skills to do that. So the short answer is, I think that speech therapy and voice retraining is an extremely important part of the process, if for no other reason that there are many aspects to speech and to voice production that feminization voice surgery in particular, we can talk about masculinization down the road, but feminization voice surgery doesn't really address things such as sound pressure levels, things such as the resonators. Now, we can address those a little bit, but we don't have the same impact that we do, for example, for pitch. Now, why do some folks wait until the very last thing that they do? A, they're giving the speech therapy and the voice retraining time, which is absolutely an appropriate thing to do for sure. But the other thing as well is for certain individuals, after voice feminization surgery, we generally don't recommend any other procedures under general anesthesia for 6 months to allow everything to heal. So that takes a big bite out of the time. So folks like to save that to the very end when they have done all of the other physical transformation.
I would also add, I have several patients who did it last because they were able to successfully achieve a very good voice with voice lessons and voice therapy. And so it wasn't a struggle in every moment of every day, but they did want to actually have the surgery because when they are surprised or having an unexpected conversation or sleepy, they can't put on their trained voice. So for them, it was like icing on the cake. They were passing, quote unquote, but they just felt like that would be like the final piece in their transition.
I think Dr. Rodman brings up an excellent point. It is conscious effort for most transgendered women to maintain that voice. And if you're also trying to maintain the voice in other aspects of your appearance, the slip-ups or the unexpected conversations can be, amazingly frightening. And additionally, a lot of research shows that you really can only think about one or two things related to your speech or to your voice at a time. So if you're worried about where the pitch is, then you're not really addressing the sound pressure levels or the prosody of the speech, which is the sing-songy way that the voice produces speech patterns. And above all, in someone who has not had a feminization procedure, their native speaking voice is still there. It has not gone away. Whereas specifically with a feminization procedure, a successful procedure eliminates most of that part of the range. So you can't slip up. You can't accidentally drop down there. It takes effort to actually get into that range.
I'm enjoying this conversation because, as otolaryngologists, we think about voice a lot. We think about perception of voice, timbre, pitch, the aspects that go into a beautiful or not so beautiful voice. And I'm thinking, if I'm suddenly woken up in the middle of the night, you can pretty much tell my gender, no matter how groggy I am. I want to point out Ms. Huff's article. There's also an article by Anthony. And these articles about speech therapy, especially for otolaryngologists, because Huff talks about ear training and really looking at pictographs of resonance and training people to hear their own voices and to modify. The Anthony one has a really nice table on staged voice therapy, which I think is really nice because I think what I'm hearing from both of you is that you do some training, maybe you do some intervention, then you do some more training, and so on and so forth. Are there people who are cisgendered or non-transitioning who will seek masculinization or feminization surgery for their voice?
Yeah, absolutely. So at least in my practice, half of the clients who come in for masculinization procedures are cisgendered males. The other half are transgendered males. And the reason for that split is actually pretty simple, and it's actually very interesting. If you have a male to female transgender and you provide them with testosterone blockers and estrogens and progestins in someone who is post-pubertal, the voice does not feminize. You do not get a raising of the pitch, etc. But if you do provide testosterone to a post-pubertal cisgendered female, the voice will masculinize in the majority of patients and actually to a significant degree. To answer your question, I will see a lot of cisgendered females that have taken testosterone not to transition, but for athletic purposes. And at the end of their athletic career, they realize that, okay, I've stopped the testosterone, my voice is not changing. And unfortunately, the voice is not expected to change. So in the 50% of cisgendered females that come for feminization, it is because that they have invariably been on testosterone for a period of time. Now, to go to a masculinization procedure, we see in that percentage of transgendered males that the voice does not drop sufficiently on testosterone therapy, seeking a deeper voice. That obviously makes sense. But we also see a number of cisgendered males that feel their voice is quote unquote too high and unable to achieve the voice that they want with speech therapy, that are presenting for masculinization procedures.
And Regina, I'm going to ask you the same question about cisgendered or non-transitioning people who might be seeking facial feminization procedures as opposed to masculinization procedures.
I get asked that sometimes, is why don't I do transgendered men? And I do, and I very much enjoy those patients. The reason I don't do more is because hormones do a very good job of changing the face in transgendered men. So they will generally grow facial hair. Their skin becomes a little thicker. Sometimes they get acne or just kind of develops a little bit of a more ruddy texture. Sometimes they lose a little bit of hair, have like a male pattern baldness. And I think especially the facial hair is just a masculine cue. They tend facially to blend in a little better and easier than the trans women. So yeah, the majority, 97% of what I do is feminization. I see some cisgendered men, usually for brow bossing. I have just a handful of patients that people tell them they look angry, or they say it's like a Neanderthal look, like, because a really heavy brow does kind of cast the brows down and it makes people look upset or dark. So I have done several of those patients. But the thing that I think is interesting is feminization for cis women. Almost all of facial plastics is feminization. So when we're doing rhinoplasty on cis women, it's almost always to make it more feminine, make it smaller, make it cuter, take down a bump. Same with chin reductions or chin augmentation. I'm trying to make the face in better harmony, which tends to be more feminine. All the injectable business that we do in cheeks, nasolabial folds, a lot of the anti-aging is all also feminization. And so there are a lot of things that go, kind of seamlessly from trans women to cis women. And I try to say that back and forth. Like when I'm counseling some of my trans patients, say about cheeks, which we can talk about later, but I think it's really important. It doesn't get as much attention on some forums and some of the kind of traditional, this is what I need in FFS, but cis women are paying billion with a B in fillers and injectables to get more cheeks. Like people, so I try to illustrate both ways to, that a lot of facial plastics just in general is feminization.
That's a really interesting way to look at it. Can I ask you, Regina, is there a minimum age or a maximum age when you're considering gender affirmation surgery for facial feminization?
I don't have a hard number. In general, I will say that insurance won't cover it or pick it up until a patient is 18. I have had patients in high school come to me and ask for surgery with the consent of their parents. The way that I approach it is the same way that I approach cisgendered patients. So I have done rhinoplasty in patients who have a really deformed, really crooked nose when they have stopped growing. So for people who are born female, that's generally 16. Born as a boy is generally closer to 18. But I usually ask, are they still needing new shoes? Are they still needing new clothes? Is stuff still changing? And if the answer is no, and they really want it and the parents are on board, I will do it. I have not done a full face whole transition, but I have done rhinoplasty on cis and trans women down to the age of 16, because if they really need it, they need it. And I don't think it's fair to say that, well, she wants her nose to be cuter so she can, have a good look in the senior pictures, but the trans woman she needs to wait till she's 18. I don't have a problem going younger because all of my patients, all of them, knew on some level that they were trans from a very early age. All of them, because I ask about this from the time that they developed an awareness, as children developed an awareness of who they are and how they fit into the world, which is usually like 3, 4, 5, they all knew that they were trans. Some of my older patients didn't have a word for it because it wasn't as popular. It wasn't in the media the way that it is now, but they all knew there was a thing about them. So I don't buy into any of this discourse that's going around in my state about how, they're not old enough to make a decision. They're not old enough to know, because they do know.
So I will direct our listeners to the Trevor Project. And there's surveys, nearly 40,000 LGBTQ youth every single year. And Dr. Rodman is 100% right. This is not a whim. This is not I'd rather change my gender than study for tomorrow's test. This is something that they have struggled with. And that word dysphoria, it's a really important word. When people are transitioning and coming to terms with what their actual heartfelt gender is, they actually change their names. And the old name is often referred to as their dead name. A dead name is a really harsh word. Like, you think about it, you're like, wow, that's the name, little Tommy was given when he was born, right? But that's a dead name to them. That's not who they are. And I think when you look at some of the data at the Trevor Project and other groups, simply having a single adult in their life who values their pronouns and their name reduces their risk of suicide and suicidal ideation by somewhere between 25 and 50%. So this is a real thing. Wonderful that we are talking about it correctly and educating ourselves and others about the correct way to deal. So, Dr. Haven, can I ask you the same question? Is there a minimum age below which you wouldn't do gender affirmation larynx surgery? And is there a maximum age? Is there a time when really, it's too late?
We have successfully operated on patients in their 60s and those even approaching 70. The problem, as I'm sure Dr. Rodman would note, with facial feminization, the biggest inconsistency is how well folks heal. So being able to perform the surgery isn't the difficult part. It's getting patients to heal the way you want them to heal that makes the biggest difference. As far as the youngest age, in general, I prefer that patients are at least the age of majority simply to participate legally in the decision-making process, because the procedures that we do are technically irreversible. By and large, I can try to undo a feminization or a masculinization, but the pitch will never be the same. The quality of the voice will never be the same. So I want to make sure that the person that I'm operating on is able to fully participate in the decision-making process. Now, that being said, there have been times when I've operated on those that are under the age of majority. And these are folks that not even within the United States, we see a lot of international clients out here in Rochester, New York, but those that have actually undergone bottom surgery and or top surgery in a foreign country. Now, in my opinion, once you have taken that step, you're pretty sure and on the direction that you're going. And I will acquiesce and go ahead and perform the voice surgery in those individuals. I prefer that they have done and are currently working with a qualified voice therapist or speech pathologist, but that is not necessarily a prerequisite for those under 18.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
Thank you. I'm Sujana Chandrasekhar. I'm speaking with the guest editors of the August 2022 issue of Otolaryngologic Clinics of North America on gender affirmation surgery in otolaryngology. They are Drs. Regina Rodman and Dr. C. Michael Haben. You can subscribe to Clinics so that you receive every single issue, which is 6 issues per year, either in hardcover or online, or you can order issues a la carte at www.oto.theclinics.com. And you can find all of our podcasts there or wherever you get your podcasts. We've talked about a lot of considerations, whether it be laryngeal surgery or facial surgery, for these patients who are undergoing gender affirmation. So, Dr. Rodman, I've never spoken to a plastic surgeon without talking about the architecture of the face. You mentioned the frontal bossing, which I think people are quite aware of. But as you said, cheekbones are not getting quite the attention that they need. There's some things going on in the lower face as well. And I know you included really beautiful articles in this issue of Clinics. There's some really nice figures in each of these articles regarding how you assess the face, and then how you assess the upper face, mid face, and lower face, and then how do you address each of those parts. And I recommend that you guys take a look at these pictures. But Regina, can you talk to us a bit about your global assessment of these patients?
Despite all of the technical descriptions that I can list, it still doesn't always hold true. There's still like a just sort of gestalt decision that we make if someone's male or female in our binary minds that doesn't always completely line up with some of the technical measurements and stuff that has been described. There has been a few studies that have been done. One by Dr. Spiegel, who wrote the first chapter, didn't describe it in this edition of Clinics, but described that essentially the top third of the face is the most important in gender identification. That recently has been followed by a very good article by Dr. Raul Seth and his group, which he talks about a little in one of the chapters, which he authored. They did a very nice study where they surveyed 1,500 male and female faces and did a 3D analysis of both and tried to compare them. And what they found was actually a little surprising. It's not exactly according to how we have traditionally thought or how some of these kind of discourse about facial feminization goes. He confirmed that brow bossing and the volume and the projection of the brow was one of the most important differences in between male and female faces. But one of the other really important differences was the volume in the cheeks. Women tend to have more volume in the malar fat pad, not necessarily higher or bigger cheekbones, but more volume in the malar frontal area of the cheeks, which makes a big difference. Some of the other differences were in the width of the alar base, some differences in the lip shape and lip volume. Surprisingly, not as much difference in jaw and chin. And so that is something we still do, but is being done, I think, less and less, or done differently. Harrison Lee and the chapter that he and his fellow authored described their technique, which I think is a very good one. Their technique reduces the width, but not necessarily the height of the jaw, because when controlled for size, male and female jaws are similar in height. It's interesting, the approach that we take is based on some of these analysis, but it's an art as much as it is a science, because for everything that we can name, oh, well, men have this, women have this, we can name somebody contrary, like, well, women have a more narrow jaw. Well, look at like Angelina Jolie, look at some of these celebrities who have a really defined and wide jaw. They still look very feminine because they have other feminine cues. So I think some of the research that's being done in facial analysis right now is really important. And now that we have technology like this to do 3D scans and do really good comparisons, they have some nice diagrams of heat maps that show the difference between male and female faces. That's all really helpful. This will never be replaced by computers or robots, because there's still something about like a human opinion, just looking at someone and being able to say, but I think we also need to do this, and this is going to balance a little bit better.
Earlier on, you said, I tell them they're going to kind of look like their sister. And I think that is really, if I take nothing home from this, that's a take home point, because it's really the same person slightly more feminine or slightly more masculine. And then, everybody uses makeup and whatnot the way they wish to do it. But I like the emphasis on the cheeks. And I like fashion is that cupid little chin is no longer the chin, right? Just like the Goldman tip is no longer the nose, right? So, and I think remembering that fashions in facial plastic surgery also change, in beauty change. As you said, there are incredibly beautiful women and handsome men out there who don't look the way we were taught that the top third, the middle third, the bottom third should absolutely look. I agree with you. I think that there's some really interesting pictures and some concepts of this 3D imaging and sort of 3D planning in your mind of what that person's going to end up looking like so that they look natural and who they now are or who they always were and now they are able to be. Can you talk to me a little bit about lip lift?
So lip lift is a very popular procedure in facial feminization. It's also gaining popularity again in cis women and cis men. I actually have several cis men who, and they don't want lip filler, but they want to show more lip, they want to show more teeth. It was very popular years ago, and cis women and men like it. Trans women, it is a great procedure. Because as we age, the white lip tends to lengthen and it tucks the red lip under. But men in general also tend to have a longer white lip and a shorter red lip. So the lip lift, which is, for anyone who hasn't seen the diagram, it's essentially cutting a little piece of skin from under the nose and lifting the lip up. What that does is it gives more show to the red lip, or more vertical show without giving it more projection, gives a little more dental show. And all of those things we do think of as feminine cues. So it looks a little sultry and soft to show just a little bit of teeth, showing more of the upper lip, creates more fullness, and it's permanent. So this is something the patient doesn't have to keep coming back, lip fillers over and over and over again. So very popular. Unfortunately, not everyone's a candidate for it. Some people, if they already have a gummy smile or they already have a lot of dental show, I will usually recommend against it. But by and large, this is one of the procedures that I also, it's kind of like the cheeks. It's like the icing on the cake. It's a little thing, but it can make a very nice difference for being a subtle, small change, but it really kind of complements everything else.
I think it's really interesting that both of you are talking about not just people who are transitioning or getting their gender affirmation, but people who just want to look and sound more like they think they need to look and sound are also using these types of procedures. So, Michael, let's talk about an Adam's apple, right? Let's talk about shaving down that very prominent thyroid cartilage. When do you do it? When do you combine that with a larynx procedure? Do you always do that, or do you just kind of bring their neck into, again, the more, usually the more feminization side? And when do you combine some laryngeal work and when do you not?
Excellent question. There's actually a great chapter in the book on specifically chondrolaryngoplasty and its role with or without part of being facial feminization and laryngeal surgery. I'm going to give you my specific biases as a laryngologist, which may differ from Dr. Rodman's being a facial plastics expert. My personal take on this is not to perform the chondrolaryngoplasty as part of the facial feminization for the reason that there are a subset of patients, especially older patients, that will require an open laryngeal surgery, such as the one that Dr. Thomas describes in his chapter on feminization laryngoplasty, and a method that I use, which is to incorporate a cricothyroid approximation as part of a feminization voice surgery. It complicates things to perform a CTA after a thyroid chondroplasty because I'm having to go through scar tissue, first of all, but even more importantly, I'm going to take that thyroid cartilage as part of the cricothyroid approximation, and I'm going to actually tip it further forward. So invariably, the chondroplasty has to be revised. Now, in those that we do not have to consider a cricothyroid approximation, I think it's perfectly acceptable and reasonable to perform it as part of facial feminization, because by and large, it is a cosmetic procedure if done correctly. And the description of it in the chapter in the book is excellent. If it's done correctly, there's really no impact negatively on the voice or on the ability to subsequently perform an endoscopic feminization voice surgery.
So is there a way for me to know who is probably going to need a CTA or a FemLAR versus who can have an endoscopic? Because right now what I do is, I see the patient and I say, are you considering voice surgery in the future at all? And I tell them if it's on the table at all, we're not going to do the Adam's apple during the FFS. I find no one really cares that it's going to be harder for you and you're going to have to struggle through scar tissue. I just tell them it's a waste of their money because he's going to do it at the same time. So save your money and put it towards voice surgery. People listen to that. So I tell them that. But I do have patients that are like, this is debilitating. This is the source of my dysphoria. Please, can you do this now? I can't have voice surgery for another year. Like, is there a guideline you would have for kind of just any like general rule for us facial plastics people?
No, I think what you're saying is excellent. That, if it's a huge source of dysphoria, I would do it and then I'll deal with it. Probably 20 to maybe up to 25% of people that I see have already had the chondroplasty. So it's not an unusual or a difficult to deal with situation. I just tell them, all right, well, I just have to simply redo it. But if you're looking for a guideline, by and large, those that have a typical cisgendered male voice and they're over the age of 40, almost invariably, I'm going to want to do a CTA just because I can't get the glottoplasty to heal well enough to get enough pitch elevation. Further, anybody who has, a very low speaking fundamental frequency that when they're working with speech therapy, they can't even get it anywhere near where they want it to be. That's also somebody that I'm fairly sure that I'm going to have to do a CTA on.
How are we in general doing with our chondrolaryngoplasties? How often do you have to do a CTA or something because of an over-aggressive Adam's apple reduction?
I don't see that much where I have to redo it because it was overdone from a cosmetic standpoint. But you bring up two good points. What I have seen are incidences of where people have actually detached the vocal cord anterior commissure from being overly aggressive, and then the voice actually drops down. It's actually one of the techniques that can be used to masculinize the voice. So that you would require additional work to try to fix, or if there's any type of, nerve damage just from overly aggressive chondroplasty.
Just for example, I have a whole procedure where I see where the cords are, I mark where they are externally, so I feel confident I'm not disrupting the anterior commissure. The complaint I have had in maybe 10% of patients is difficulty changing pitch. And so I think it's the rocking of the larynx. It's not so much that the pitch drops, but they just can't quite change as easily. Is there something that can help with that?
There shouldn't be a limitation of the ability for the cricothyroids to move the thyroid cartilage and tighten the cords and get the elevated pitch unless the thyroid cartilage is scarred down. That's easy to pick up because when they swallow, the skin puckers. And I'm sure you've seen that in other people's overly aggressive or not very good closure. The counterpoint that I wanted to make, and this is where I need your expertise, is that in those that come in fortunate enough to have thin, long necks, the ability to see any undulation, any irregularity in the thyroid cartilage, it's quite prominent in certain individuals. And I'm wondering, do you have a specific trick outside of a good muscle closure to try to smooth out some of the irregularities that you really can't get to because it is below the level of where the cords attach, or it is related to, muscular attachments?
Yes. So I will use either a drill or just a blade to kind of file it. Like, I'm not trying to actually cut through the cartilage or cut deep, but often at the apex of where I do the Adam's apple reduction, there's still a little bit of a prominence. And I find that in older patients, a drill works really nicely to just at least round it. So it's still a little bit of a prominence, but it's not a sharp point. In younger patients, a lot of times I just take like an 11 blade and I just kind of scrape it, file it essentially. And then I am really careful about the muscle closure to try to give an additional layer over those irregularities.
One thing that I have done, and I would love your opinion on this, especially for younger patients with, softer cartilages, instead of actually, like you said, drilling through on the lateral portions, the lamina, I have a tendency to drill it almost as thin as I can and just over sew it as opposed to resecting it. Do you have any opinion as to doing that versus actually removing the cartilage, especially on the superior border, more through and through?
I still remove it, mostly because I find even if you can't see it, patients will complain that they can feel it. That's really my test in the OR, is I try to see how it looks, but also how it feels externally, because I find that is often the thing that they're looking for. They want to be able to feel their neck and feel it be smooth. So I guess I don't have an opinion. I think as long as it feels smooth, it's probably just fine.
If someone comes in just for an isolated thyroid chondroplasty, will you use a submental or an intraoral or a transcervical in general?
I almost always do it right at the cervical mental angle. So kind of right where their chin meets their neck. I find that for almost everybody that hides really nicely. Only in older patients, I'll use the highest crease in their neck if they already have a crease. But generally, the transition, even a few millimeters above that, is where I go. I know people do these transoral approaches. I just don't know how that's going to turn out over time in terms of like skin sagging, chin ptosis. And I feel like it's sometimes a difficult operation as it is, depending on how ossified the cartilage is. Being even farther away, I just think adds like a layer of risk that I'm not comfortable with.
I would have to agree.
Well, I have really loved this dialogue. I want to wrap up and I want to thank you both. It's an excellent issue and it's an excellent conversation that we're having. I know, Dr. Rodman, you touched a little bit on the politics. Suffice it to say, all of us believe that politics does not belong in healthcare and that we are here to take care of the patient and the family that's in front of us. What I am interested in, and we talked a little bit before we started recording, is how are we standardizing training and guidelines and best practices? I think I'll start with Dr. Haben. How are we making sure that our residents in various geographical areas have access to the correct training? And how do we make sure that we are communicating across subspecialties so that the plastic surgeons and the laryngologists are talking to each other about when do you do certain aspects of this care?
An excellent question. And again, pointing readers back to the book, I think there's an excellent chapter on resident training by Dr. Nguyen and Dr. Thomas. I guess where I would go with it is this. If we were to look at bariatric surgery, for example, most places you do not get permission to do bariatric surgery with insurance coverage unless you're a center of excellence. So you've demonstrated not only experience with the procedures and having done a certain number of them, but then the insurance companies tend to send their patients towards these centers. None of that exists with transgender health. Now, there is a what's called a WPATH, which is the World Professional Association for Transgender Health, and they have very specific guidelines for both top and bottom surgery. Some folks will apply some of the standards, and this is demonstrated in several different chapters in the book, including those on hormone therapy. They will apply the guidelines to procedures in otolaryngology, which are considered irreversible, but there is no mandate to do that. As such, there are no centers for excellence. One of the things that I think we need is some sort of a standardization where residents can get training and there is a better, not only communication amongst providers, but a coordination of care. Right now, the way it exists, there's only a few centers with a very long wait list, and only those that have the financial means to get to these centers, such as the one in New York City, one in San Francisco, et cetera, are able to access it. The final point I would like to make is addressing the approach to non-binary transgender patients. This needs to be started in medical school. This is not something that we should be starting off in residency just because otolaryngology, like plastic surgery, like endocrinology, are seeing more of these patients. I think the ability to understand, what our patients are going through needs to be part of medical school training.
Absolutely second that this needs to be taught earlier. Even if we're just teaching basic care, pronouns, basic information about hormone therapy, basic information about available options for voice surgery, top surgery, bottom surgery, face surgery. A med student doesn't need to know how to do a type 3 brow bossing reduction, but they need to know in some level that it exists and that it's possible. And that's kind of was one of my real hopes from this issue of clinics, is to at least be able to educate general ENTs and anyone else who reads it. Expect everyone to be able to do, like I said, a type 3 brow bossing after this, but to have some idea about what's involved, what the patient went through, so that if they do come to your practice with sinus issues, you understand what has happened to them, why they went through it, what it looks like. When you get a CT scan, you won't be surprised that there's little titanium plates. You'd know to expect that. So that's really what I'm hoping comes out of this kind of work that we're doing right now. I also really think like what we need is some kind of clinical practice guidelines and standards. Like we were talking before, it's really the Wild West right now. The good news is that more and more physicians are becoming involved in this and trying to learn it. It's still so new to be adopted. It's not new surgery. It's new to be widely adopted. There's not great standards. I also wrote a review article recently. There is more and more publications coming out as more and more academic centers start to do this kind of work. There's more and more publications coming out about complications and what to expect and just kind of overviews of the surgery. So I'm hoping that as those continue to be published, we can develop some guidelines so that all physicians are able to at least see these patients, especially see these patients post-op, like what Dr. Hib and I were talking about earlier. Like in my dream, there would be some kind of a network of other otolaryngologists who, most of my patients come from out of town. If I could, call up Dr. Blank in Salem, Oregon and say, hey, this patient's complaining of whatever, inability to change pitch after her Adam's apple reduction. And that physician at least know enough to understand what the surgery is and be able to do a scope and decide, does she need a laryngologist? Does she need this, that, or does she just need a little more time? That would be my dream.
Well, thank you. I think that you two both are definitely on the cusp of educating on such an important subject. And I really appreciate all the time and effort that you took to compile these articles, to pick the right authors, to really make the issue flow so that somebody like me can pick it up and really end up being much better educated about this than I was before I read it. So again, I'm Dr. Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America. I've been speaking with the guest editors of the August 2022 issue of Clinics, which is on gender affirmation surgery in otolaryngology. My guests today have been Dr. Regina Rodman from Houston, Texas, and Dr. C. Michael Hayden from Rochester, New York. Dr. Rodman is a facial plastic surgeon and owner of Face Forward, which is a private practice in Houston, Texas. Dr. Hayden is a laryngologist and director of the Center for the Care of the Professional Voice, Hayden Practice for Voice and Laryngeal Laser Surgery in Rochester, New York. Thank you both for putting this issue together, for taking the time to share your knowledge and your questions for each other with our listeners today.
Yes, thank you so much to both of you for your help in organizing and coordinating the voice chapters. It's been a really good experience for me.
Thank you for joining us for this edition of the Otolaryngologic Clinics podcast series. For an exclusive discount on the issue we discussed today, focusing on gender affirmation surgery in otolaryngology, visit us.elsevierhealth.com/expert. Otolaryngologic Clinics is available for individual print subscription with accompanying online access or individual online-only access, and is also available on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter and subscribe to the Otolaryngologic Clinics podcast wherever you get your podcasts.